A mandibular first molar with 4 roots. Rare but real.
Come with us to see the clinical management based on the guidelines.
Eddie, have you ever thought about the significance of untreated canals in teeth? It's quite fascinating how they can harbor bacterial issues and even lead to failure of root canal treatments.
Absolutely. Untreated canals indeed cause a lot of problems. Having a good understanding of the unique morphology of the teeth can really make a difference in endodontic treatment success.
Exactly. An understanding of uncommon tooth morphology allows clinicians to effectively clean and treat the entire root canal complex. For instance, when dealing with mandibular molars, they usually have 2 roots, one mesial and one distal.
Yes, but there is an interesting variation mentioned by Carbelli in 1844, an additional third root. They call it radix entomolaris and radix paramolaris for the distal lingual and mesiobuccal supplemental roots, respectively.
Exactly. It's interesting how well documented these variations are. Most publications talk about these 3 rooted molars, but here is something rare. Did you know that there are cases of mandibular molars with 4 roots? It's quite uncommon.
So, what's the approach to handling these cases with unusual root structures?
The first step is accurate diagnosis. Traditional dental radiographs can sometimes be limited due to the superimposition of 3 dimensional structures onto a 2 dimensional image. This is where dental CT scan comes in. It's a great advancement that allows us to visualize dental anatomy in 3 dimensions.
What about treatment? How does this rare morphology affect endodontic procedure?
Dealing with these variations requires a thoughtful approach in designing access cavity, locating root canal orifices, and effectively cleaning the root canal system. This paper we're discussing actually highlights a case of a four-rooted mandibular molar where the diagnosis was aided by a spiral CT integrated with DentaScan software.
Let's check this interesting case. It's about a 15-year-old boy that his chief complaint was pain in the lower left back region of his mouth. He had been experiencing this for about 2 weeks.
Well, upon examination, they found a decayed left mandibular first molar, tooth number 36. It was tender to vertical percussion, but the mobility was within normal limits. Interestingly, cold and electric pulp test did not show any response.
The intraoral periapical radiograph shows a double leaning of the periodontal ligament, suggesting an accessory root. They even used a 30-degree mesial angulation intraoral periapical, which gave them a clear view of 2 extra roots with diverging termini.
To confirm and understand the root canal configuration, they opted for a spiral CT scan. The scan images revealed a type 1 root canal configuration in each of the 4 roots.
Based on their assessment, they diagnosed pulpal necrosis with symptomatic apical periodontitis. That's when they decide to plan for endodontic treatment.
They began by administering local anesthesia and preparing the access cavity in a conventional triangular outline form. They were able to locate 3 orifices corresponding to the mesiobuccal, mesiolingual, and distobuccal roots.
They discovered a unique pattern of developmental root fusion lines forming an X configuration on the pulpal chamber floor. They carefully extended the access cavity to expose the distal lingual root canal orifice using ultrasonic tips.
Well, they encountered a bit of challenge with the entrance to distal lingual root canal orifice. It was blocked by calcification. They managed to clear this blockage using ultrasonic tips and gained access to the canal.
After negotiating all root canals with a 10K file and confirming working lengths, they used a crown down technique with per-taper gold rotary files. Cleaning and shaping involved sequential irrigation with sodium hypochlorite and EDTA.
Following the cleaning and shaping, they placed a calcium hydroxide intracanal medicament, and the access cavity was temporarily sealed, and the patient was recalled after 1 week. At the next appointment, the patient was asymptomatic.
The canals were dried and obturated with F2 pro-taper gutta-percha and AH plus sealer. A post-endodontic permanent restoration was completed, and they placed a full-coverage porcelain crown. The patient remained asymptomatic during the follow-up visits, and the case ended on a positive note.
So, essentially, a combination of advanced imaging, detailed clinical assessment, and precise instrumentation played a crucial role in managing these complex cases. Now, let's wrap things up with the conclusion of this article. It's all about the importance of being prepared for variations in endodontic anatomy.
Absolutely. The conclusion emphasizes the need for clinicians to be familiar with and anticipate these anatomical variations.
Besides, careful analysis of preoperative radiographs from different angles was crucial. But the authors didn't stop there. They also used three-dimensional scan images to get a more comprehensive view.
And they didn't neglect the clinical aspects. The modification of the access cavity outline based on the dentinal map guide of the pulp chamber floor played a role too.
Couldn't agree more.
Well, that's it, friends. Thanks for joining us today. Hope you learned something new.
Sure, and don't forget to join the Perfect Biopsy family and never miss a moment. Goodbye.